Yeah, apparently they were doing some other site. Yeah, hemolysis by 2
You have it just
yeah, it must be. Or it must be the rattle, I don't know, but they did it in
You lock
the
lock
and
it.
it doesn't
No,
and
no.
it's the same collection drop.
Same job.
And I was like, that's really good today.
Good evening, everybody.
Provide counsel with expert tailored advice for any registering situation. No reason is too big or small, and it's another set of eyes to ensure accuracy and secure all the deductions during silences. So don't get stuck on fun. Go ahead and shout
No,
it out.
someone's got a TV on.
Yeah.
Oh, is it? Okay. So can I ask all the remote sites to mute? We've got 1, 2, 3, 4 of our current 4th year students that are going to present for your delight this evening. I hope you enjoyed it. This is their...
Colin, can you turn the telly down a bit? But someone just commented they could hear it. Thanks. Sorry.
Yeah, all right. How are you?
Good.
That's good. So we've got 4 students and this is their first placement, so be kind to them. They've got to present a case study from their placement, and often they choose topics that include some of the subjects that they haven't studied yet. So it's all about a learning exercise, and hopefully they've been ably prepared by all the scientists here in Townsville. So thank you very much for joining us. I hope if you're at a remote site you've got something to eat, because if you are able to scan around the room here, you'd see there was 9 pizzas sitting here, and I don't think there's terribly many of us in the audience. So I can post one. We can electronically post one if anybody's hungry, so just stick your hand up if you want some pizza, although I do see that the boys are doing not a bad job on those pizzas. Anyway, I'll get off the stage. Our first speaker tonight is Sohan, so please make him welcome.
Good evening, everybody. Today I am presenting a case study highlighting the effects of liver cirrhosis on the coagulation profile of a patient. The patient was a 68-year-old female who presented at TTH on the 11th of June and was given a new diagnosis of liver cirrhosis. Her blood culture was positive for E. coli within 10 hours, and it was noted this bacteremia was the likely cause of her acute liver failure. Her liver impairment consequently affected albumin synthesis and increased her liver enzymes. Firstly, I will briefly explain how coagulation works. Primary hemostasis can be easily described as the formation of a platelet plug, beginning with platelet adhesion, where they attach to collagen and is enhanced by collagen-bound von Willebrand's factor. The activation of platelets by agonists confers a shape change, which facilitates the secretion of platelet granules and an active glycoprotein 2B3A complex to interlink platelets with fibrinogen, forming a platelet plug. This is essentially primary hemostasis. Secondary hemostasis is the reinforcement of a clot by fibrin formation and is achieved through the intrinsic or extrinsic pathway, which converges into the common pathway, also known as the prothrombinase complex, resulting in the formation of fibrin by a catalyst known as thrombin. Also, our bodies have methods in which they break down clots and prevent further coagulation. Heparin-like molecules form a complex with antithrombin 3, and this complex ultimately prevents the formation of fibrin. Furthermore, thrombomodulin present on endothelial cells converts thrombin to an anticoagulant capable of activating protein C, and with the additional help of protein S, inactivates factor V and 8, which involve the intrinsic and common pathways. Lastly, the fibrinolytic system enzymatically breaks down clots by converting plasminogen into plasmin. This conversion is achieved by the secretion of tissue plasminogen activator and urokinase, resulting in fibrin degradation products. So how is all this affected by the liver? As you can see with our patient, all her test results increased in relation to her coagulation studies. This makes sense, especially with cirrhosis, which is characterized by reduced synthesis of procoagulant and anticoagulant substances. The liver is responsible for the synthesis of almost all coagulation proteins except factor VIII and von Willebrand's factor. And this deficiency directly affects tests we do routinely in the laboratory. These abnormalities seen in patients would normally indicate a bleeding tendency, but it isn't the case in patients with liver disease. Most patients with liver disease are in a rebalanced hemostasis, as both the pro and anticoagulant pathways are decreased. As you can see on this slide, I have noted some observations seen in each stage of coagulation, and I will begin to explain how each stage is affected in a little bit more detail in regards to cirrhosis. Firstly, in primary hemostasis, platelet function and aggregation is important. Mild to moderately low platelet counts are typically observed and is due to splenic sequestration, essentially a result of portal hypertension due to the disease state. Also, decreased thrombopoietin levels have also been suggested as a possible cause of the decreased platelet presence. However, this is counterbalanced by an increase in factor VIII and von Willebrand's factor, commonly seen in patients with cirrhosis. Von Willebrand's factor is increased due to the stress upon the endothelial due to portal hypertension and or endotoxemia. The affected clearance rate of the liver is also associated with an increase in factor VIII and von Willebrand factor levels. This increase overcomes the thrombocytopenia and consequent abnormalities in platelet aggregation. And more recent studies have provided.
Sorry, the external people can only see your title slide.
Oh, that was that work.
I just think we wanted just, anyway, keep on.
Okay.
Hello, it's Rockhampton here. We can see the slides you're putting up. No problem for us.
Oh, okay.
Oh, okay.
That's good to hear.
Thank
Lovely.
you.
Thank you, Rockhampton.
Okay, so more recent studies have provided evidence speculating that large amounts of von Willebrand's factor enhancing platelet adherence is to be the cause of thrombocytopenia in liver cirrhosis. Furthermore, for interest's sake, an in vitro study was conducted, and it was found that platelets of patients with cirrhosis in normal plasma displayed defective platelet adherence. However, platelet adherence increased in the presence of plasma from cirrhosis patients. Furthermore, the study also found that when normal platelets were resuspended in either normal plasma or plasma from patients with cirrhosis in conditions representing thrombocytopenia, the cirrhosis plasma displayed greater platelet deposits. So therefore, the quantitative increase in von Willebrand's factor outweighs possible qualitative defects or a low platelet count in patients. Secondly, the coagulation proteins influence the efficiency of the secondary hemostasis. However, in patients with cirrhosis, the lower levels of procoagulant proteins are accompanied by decreased levels of anticoagulants such as antithrombin, protein C, and S. This fragile state of maintained hemostasis can be easily tipped to a hyper or hypocoagulable state. For instance, using our patient as an example, the bacteremia may have potentially pushed our patient's already critical coagulation state over the edge, inducing a hypercoagulable state. This causes a similar clinical condition to BIC known as accelerated intravascular coagulation and fibrinolysis, or otherwise known as AICS, which is considered to be a result of clots being susceptible to plasmin degradation due to elevated levels of tissue plasminogen activator and inadequate release of plasmin inhibitor. Keeping in mind that plasminogen production has also decreased as it's produced by the liver, but a local concentration is present on clot surfaces. The main difference between DIC and AICF is the higher factor VIII levels observed in AICF, but otherwise it's quite difficult to distinguish. And now I will compare our patient with all clinical outcomes typically observed in patients with cirrhosis. So in regards to the primary hemostasis, 1 Willebrand's factor assay wasn't conducted. However, the patient did have high factor VIII levels, which coincides with the idea of an upregulated primary hemostasis compensating for the thrombocytopenia and also possibly a diminished secondary hemostasis. Furthermore, mixing studies were performed and were partially corrected, and then the patient was investigated for a lupus anticoagulant, however was a false positive, and no conclusive results were reached. Also, her ECOS time was prolonged, which suggests a factor deficiency due to liver disease, and additionally, her coagulation profile was consistently prolonged and also had a high D-dimer level indicative of fibrinolysis. And as I previously explained, the decreased factor production accounts for the prolonged coagulation studies, and AICF is likely responsible for the increase in D-dimers, in addition to the upregulation of tissue plasminogen. So a reason for the AICF is the bacteremia the patient experienced influencing her into a hypercoagulable state, and consequently promoting further fibrinolysis. And upon analysis of her blood film, moderate fragments were observed, and when using the International Society of Thrombosis and Hemostasis system to derive a prognostic score in regards to DIC, our patient fits into the overt DIC category with a score of 5. However, the patient's factor 9 was low and factor 8 was high, and this doesn't follow the general understanding of DIC. Therefore, it's more likely the patient was experiencing AICF due to a heightened primary hemostasis, rebalanced secondary hemostasis, and active fibrinolytic phase, as well as bacteremia. So, in summary, patients with liver disease add a level of complexity to an already complex cascade, whilst maintaining a fragile, rebalanced state of hemostasis, which is easily disrupted by any physiological stressful event. The patient remains in a constant state of limbo, however, more likely favoring procoagulation unless the patient advances in terms of liver disease severity, which increases the risk of bleeding. The goal of the presentation was to serve as a reminder as to how liver disease can impact coagulation profiles and provide a brief insight to what is happening within the patient. Thank you.
We'll go to the regions first. Does anybody have any questions out remotely?
No.
Okay, I think you're off the hook, so Han. So,
Hang on, can I ask you a question?
off you go. You have one.
All right, you didn't mention the fact that they were considering hemolysis in this patient.
Yes, so
So
that was
what
just
two
a-
what two things did they test for?
they checked on the patient's haptoglobin, and it was extremely low, but there was no evidence of hemolysis in the patient sample, and also haptoglobin is produced by the liver. So when the liver is diseased, it's likely that haptoglobin is also lowered. So
But what sort of fragments were they
fragments.
that they saw in the film?
What sort of fragments? Just a normal type of fragment?
So how did they rule out TTP?
Oh, yeah, so they were considering TTP as another possible cause, but they did an ADAM TS13 assay, and it was at the lower levels of normal, and so that ruled out TTP, but in patients, cirrhosis patients, the ADAM TS13 is generally normal except for advanced stages. So Yeah, it kind of fits in with the patient profile.
We actually just had another patient today with liver-inspired hemolysis of some sort, probably a spur cell hemolytic anemia.
Yeah.
Had low haptoglobin, which was confusing everybody. I went, aha! Low haptoglobin in liver disease. Yeah. Very interesting.
Which not a lot of people know.
No.
No, I didn't know that
This is
until you
really
told
great.
me. So I was disappointed you didn't put it in your talk.
What did the liver functions look like?
That's why you don't invite biochemistry people.
Sorry, he hasn't understood biochemistry, so I'm limiting it.
You haven't taught us that yet.
Oh, careful what you wish for.
Yeah.
It's like 2 weeks to that, Donna. Don't worry, she'll teach you extra hard now.
Yeah. That's
It's alright, so if it's not there immediately, that's okay. I was just interested.
Here's something he prepared earlier.
That's the.
Oh, look at that. Well done.
Look at that, yeah.
Yeah.
Yeah, so I was wondering,
But that one
it's really liver disease, not
that one
cirrhosis.
today wasn't.
Where does the cirrhosis?
It was alcohol induced, and that's what all the
Yeah,
notes.
so alcoholic liver disease,
Yeah.
like fatty liver disease,
Yeah.
probably, because those enzymes are still quite elevated, aren't they?
Yeah.
What's the albumin? 23. So the albumin gives you an indication of whether or not they're manufacturing any proteins, but it's also you've got a dietary component to that too. So when you're an alcoholic, you don't eat anything because you've got lots of carbohydrates on
Yep.
board.
Did that patient make it?
Nah, she
No.
passed away on the 18th of July.
And this is why they didn't follow up the loop.
What did you say, Ailey?
Yeah.
What did you say? Sorry?
She passed away, and that's why they didn't follow up on the positive lupus, because Joanne Beggs actually rang me
Okay.
and said, is the sample contaminated with an anti-10A? I
Right.
was like, no, I doubt.
So why
I
was
doubt they've
it,
given
why,
her.
like, what
Just
was
because
the-
anything that's interfering with your APTT,
Okay,
it's all APTT based assays,
Right.
so it's going to interfere.
right.
It's just very difficult to do testing.
Yep.
Right, well done.
Good job.
Good stuff.
Who's next? So our next student is Paul Baker.
Yay.
Oh, okay.
I appreciate you.
Thanks.
Trying to get the colour scheme to match JCU. I thought it worked well.
Yeah, they really chose the easy topics, these guys.
Oh,
Yeah, I was going to say, I think so.
I think when I asked you, you said, frankly, I don't fully understand it.
It can be a good tactic, though, to go for something that nobody understands.
Okay, so let's get started.
Yeah, we've seen your title.
Okay. Hey guys, and people who don't know me, my name is Paul Baker. I'm a fourth year Med Lab Science student at JCU. I'm here to talk about early T-cell precursor acute lymphoblastic leukemia, with a specific focus on the testing and diagnostic challenges with the interpretation of testing. So here's an outline. First, I'm going to talk about what ETP-ALL is. Then I'll go through two separate case studies, one from our lab and one from recent literature. Then I'll field questions, and hopefully I won't leave too many holes. Definition. ETP-ALL is a neoplasm composed of committed cells to T-cell lineage, but not irreversibly committed. They display a unique immunophenotype indicative of limited early T-cell differentiation. It's quite an uncommon disease found in children and adults. In children, 10 to 13% of T-ALL cases are ETP, and in adults that's 5 to 10%. So not super rare, but also not super common. It's currently believed that the origin of the malignancy is derived from cells that have moved from the bone marrow into the thymus, but have not yet irreversibly committed to the T-cell lineage. So they still retain the potential for myeloid or dendritic cell differentiation. So they'll display some really wacky stuff. Microscopically, the blasts look a lot like other ALLs, small to medium size, scant cytoplasm, although that's a trap. A lot of them seem to have more cytoplasm than you'd expect from a blast. They have inconspicuous nucleoli, which also makes them difficult to identify, because if you're scrolling past quickly and you see quite a bit of cytoplasm, no distinct nucleoli, you're like, abnormal lymph, move on, or regular lymph, move on. So it's quite an insidious little bastard. It's mainly characterized immunophenotypically according to WHO guidelines. So expressing CD7, lacking CD8 and CD1A, and expressing one or more myeloid or stem cell markers, which are listed here, is the main criteria for diagnosis. But beyond that point, they also tend to express cytoplasmic CD3, but not surface CD3. CD5 is often negative, but when positive, below 75% representation is still indicative of ETP. MPO is negative. That one is very important from separating it from some other diagnoses. The genetic profile of the disease is more similar to a myeloid leukemia than a lymphoid. A high mutation frequency of specific genes, but no gene has been identified which itself points to ETP-ALL. Most of the genetic studies are used for treatment and prognosis purposes, not diagnostic. On to prognosis. I know, beautiful segue. Initial descriptions had ETP being a high-risk leukemia with worse outcomes than other TALLs, but then later studies had a smaller difference, and the most recent largest study had no significant difference whatsoever. So it's sort of on the fence a bit with that one. So let's move on to our cases. Case 1. We have a 25-year-old man. He presents with multiple bilateral neck swelling, weight loss, and a low-grade fever for 1 month. After admission, he's sent for an ultrasound that shows bilateral cervical lymphadenopathy. LDH is elevated, but liver and renal functions are normal. Hemoglobin's low, white cell count's really high. He's got a bit of a thrombocytopenia as well. Peripheral blood shows 88% blasts, characterized as having scant cytoplasm and indistinct nucleoli. That sounds familiar. So they did a bone marrow on him, showed near replacement by blasts, morphology consistent with peripheral blood findings. There are a few blasts containing our rods which were MPO positive, and the flow cytometry was pretty consistent with ETP. You've got your CCD3, your CD7 positive, 1A and 8 negative, MPO negative. Looks like an ETP-ALL, right? Well, it's not. Just because it looks like a duck and quacks like a duck doesn't mean it's a duck. This one is a cormorant in disguise. But why is it not ETP-ALL? The presence of the MPO positive our rod containing cells. So MPO is essentially a definitive marker of myeloid lineage. So these aren't just T cells with aberrancy, these are actual myeloid cells. So this is a mixed phenotype acute leukemia, not an ETP-ALL. Pull a sneaky one on you there. On to case 2. A 51-year-old female presented to ED with left-sided chest pain, shortness of breath for 3 to 4 weeks, and a cough. She was initially diagnosed with a left-side pleural effusion and sent for a chest CT, as well as blood sent for analysis. These are her bloods. As you can see, a little bit of thrombocytopenia, white cell count a bit high. Upon revision of the film, there were a section of cells that were determined to be others, which were abnormal small lymphocytic cells, high NC ratio, prominent nuclei. So blast looking. The CT scan showed an anterior mediastinal mass measuring 10 by 7 by 9 with no signs of invasion to lymph nodes, consistent with lymphoma or a thymoma. Now this image is not from our patient. I couldn't get a hold of her physician in order to get any images, but this is from a patient with ETP-ALL, just to illustrate people who don't know what it is. That's where the mediastinal mass would be and the approximate size. At this point, they ordered a biopsy of the mediastinal mass and sent lung fluid for cytology. The biopsy showed a core composed of small to medium-sized uniform cells, inconspicuous nucleoli, scant cytoplasm. We've heard that story before. But these ones were a bit off. CD3 is positive, 7 is positive, 8 is positive, 1A is positive. That doesn't look like an ETP. That's more consistent with a T-cell lymphoblastic lymphoma. So, try and correlate that with more of our findings. The pleural fluid was highly cellular. A large number of atypical lymphoid cells. Once again, consistent with our ETP cells and other blasts. I can't just say everything's ETP. It's just consistent with blasts, really. The appearance was suggestive of a malignant lymphoma, but that also had to be correlated with further testing. Flow cytometry of the pleural fluid showed the abnormal cells accounted for above 50% of the nucleated cell population. They were positive for CCD3 and CD7, negative for CD1A and surface CD3. Now these look more like it, consistent with a good T-cell ALL. Well, as good as a T-cell ALL could be. So we ordered bone marrow, flow on the bone marrow, and a molecular translocation pattern. Now, as I said before, genetics is not diagnostic in this case, it's more prognostic. But in this case, our patient showed none of the typical translocations found in leukemias. The bone marrow flow. So we did flow on the bone marrow, of course. It showed almost exactly what we wanted it to. CCD3 positive. The CD1A, 5 and CD8 are all like in that weak to negative range. So maybe a little more positive than we want, but it's still there. CD7 is very positive. And then we've got our few extra myeloid stem cell markers like our HLA-DR is negative, our CD13 is positive. That gives us what we need. So most of these are fairly consistent, but that's not a nail in the coffin. So I thought I'd look a little deeper. Instead of splitting hairs, I'll look at the actual diagrams. So for people who either hate or don't understand flow, this is going to be super boring. And to people who do like it or understand it, I'm going to butcher this and I'm sorry. Okay. I don't think I can be seen by the people over the internet, so I'm going to use a pointer for a moment. So this is side scatter area versus CD5, which is just a lymphoid marker. This population up the top, these are our myeloid cells. These are our monocytic cells. These are our lymphocytes. Over here is mainly red cells and debris. That concentrated area in the center that we've gated normally wouldn't be there. Those are our offending blast cells. So everything from here will just be characterizing those cells.
Nailed it.
Thank you, Ellie. CD3, that's surface CD3, is intended to be negative, as it is. CD7, intended to be positive, as it is. That's a beautiful cluster. 3 negative, 7 positive. 3 negative again, but this time we've got our CD5. We've got almost an exact 50-50 split between positive and negative there. But for people who pay attention at the start, anything of 75% or less positive for CD5 is still indicative of ETP ALL. Then there's this bastard. By definition, WHO states that CD8 should be negative, but we've just got mostly negative. We've got about 85% negative, and at that point, I honestly don't know if that's strong enough to call CD8 negative, so I'm going to leave that up to the hematologists, and they did their job like they should, and decided it looks like a duck, quacks like a duck, has the clinical presentation of a duck, 85% immunophenotypically consistent with a duck. That, my friends, is a duck. Special thanks to Ailey Ross and Andrew Cross for helping me gather information and interpret some of this.
Once again, go to the regions. Has anybody in the regions got any questions for Paul? All shaking heads. No.
I think.
Is that a hand?
Oh.
No, that
was stretching.
Stretching. We haven't brought anybody to tears as of yet. All right, I'll throw it to council, but just butt in if anybody comes up with a question.
Okay, what do you guys got?
Oh no, I wanted bird facts.
Oh, I have some. A fully grown hummingbird weighs less than a 10-cent piece. Continue.
Oh, bird facts, more birds. Can I just make a couple of comments? Because I don't want to, you did a very good job of explaining the flow, so I don't burden you with a flow question. But interestingly, the cytoplasmic TDT was negative in the bone marrow, but it was positive on the tissue. So we can't really explain that.
Yes, I did note that, but I had no explanation.
So it's best not to mention it.
Yeah, of course. Don't draw attention to what you can't explain.
And the other noteworthy thing was this poor woman, she presented to her GP, and her GP told her she was unfit. And that's why she couldn't breathe properly.
And a pleural
And she
effusion.
had pleural effusion with 67% TAL. If you're not sure, get a second opinion from another GP.
Better one.
So, prognosis?
Prognosis is quite good. As of now, she's on, I can't remember the exact protocol, but she's on chemo. All her numbers had come crashing down into normal. As expected, she's a bit neutropenic now, but yeah, everything looks like it's proceeding as it should, with no obvious notes on the clinical sheets.
I wanted to use her sample to validate my new flow cytometer, but she's got no circulating blood, so that's good for her.
Exactly. The blood is looking wonderful.
Yeah.
Not even
So I was
flaggy.
excited she didn't have any blood, so that's good.
So is this something like if we were really confused and we sent it for like DNA analysis?
Yeah, they have sent it away for a complicated molecular test.
Oh yeah,
So,
there are tests being sent that haven't come back yet.
yeah,
I just used what I could.
yeah. Which may or may not be conclusive, but they say clinically it fits with an ALL and the treatment, Ms. Taylor, which seems to work.
I've been told it's certain,
Yeah.
because I questioned it.
On the
You
flow
did.
initially,
Hmm?
it didn't look like an ALL.
I was no, because it looked mature.
It did look,
The actual
yeah.
morphology looked quite
And the
mature.
pen was very bright.
Yeah. So it was a bit of a confusing case.
Any more questions?
Yeah, I was just going to say, you've just presented 2 cases of adults with ALL. How
Yes.
common is that?
Not super common, no. ALL is generally a childhood disease. Like, I would say that's extremely rare at that point.
Our recent childhood cases have been AMLs.
Yeah.
Oh.
We had 2 ALLs and this lady in the BAL, so we had 2 ALLs.
Yeah, so
2 weeks
probably-
ago.
Anecdotally, I don't have the exact number, it'd probably be about 25 to 30% adult. Yeah.
Wow, so it's still quite high.
Yeah, that's the one I thought.
Because remember, CML can accelerate
Exactly.
into an ALL, which
Yep.
was one of
Yeah,
ours
this
as
is why
well.
it's worth
10
looking at the
weeks.
BCI and everything. Yep.
CML. CML.
Okay, cool. I'm going to run away before someone thinks of something. Thank you.
Okay, our next speaker is Jordan. So, thank you, Jordan.
Oh, yeah.
Blaine's going to ask you to share all the case studies with him, so he can use them for his students. You shouldn't.
It's already been berated by Rob.
Good evening, everyone. My name is Jordan Frankel, and tonight I'd like to talk about a problematic case that occurred in Mount Isa, and further about a topic from this case which I found very interesting. So, to begin this case, on the 21st of June at 3 a.m. in the morning, a 21-year-old male patient presented to the Mount Isa hospital with a stab wound. The patient was rushed to the ED and supplied one O-negative medevac unit. A sample was then collected and sent to the lab, with a group and hold requested, and asked for a further 6 units of cross-matched blood ASAP. Now, upon completing the initial group check, the patient was found to be O-negative, which became a problem because upon previous admissions, the patient was grouped as O-positive. So immediately you begin thinking, what's going on here, and what possible reasons could cause this? The first one that should come to mind would be, is this sample from the correct patient? Now, the check was rerun and found the same result again. Both were O-negative and no mixed field was seen, a feature which you would expect from a patient that had just been transfused. So, some other possible reasons for this result could be maybe the patient has changed blood groups, which can happen for various reasons, but it's rare. And nothing was noted in the patient history, and the patient had had a sample taken only 5 days earlier, giving a result of O-positive. So this isn't likely. Okay, maybe there's a labelling or collection error, which would lead back to the first point of probably not being the right patient. Without further information, this would have been a really hard and probably very stressful time for the laboratory staff at the Mount Isa Hospital, trying to figure out what had happened. So eventually, after a phone call to the doctors treating this patient and the resultant investigation, it was concluded the collection of the sample occurred from the same arm and possibly the same line as the medevac unit was transfused to, thus contaminating the sample and having a collection representative of the blood donor bag rather than the patient. This then accounts for the strong group check seen with no sign of a mixed field, and obviously why the patient group did not match with the sample. Another aspect from this case that was irregular was the biochemical analysis
that was ran on the initial blood sample taken from the patient. Now at this point, it's important to remember the initial sample was nearly directly from the donor bag and was not representative of the patient. So the results panel from this analysis is shown on this slide here. And as you can see, some results stick out straight away. Namely, the very high potassium, along with the low levels of bicarbonate and also sodium. Which at first, this is quite worrying. If this were an actual representation of the patient's peripheral blood values, then the patient should be dead. A potassium of 33.8 millimolar per litre is huge. That's greater than 6 times the healthy level. To give this value some context, a patient with a serum potassium of roughly 8 is considered fatal, putting the patient in a state of severe hyperkalemia, which can then lead into asystolic cardiac arrest. Furthermore, the very low bicarbonate level could indicate the patient is also in metabolic acidosis. A panel of results like this has very scary implications. But before jumping into these conclusions, we should have a further look at the specific donor bag used in this case. Because as we already found out, the contaminated sample, this was what contaminated the sample, and as such, this was representative of the donor bag and not the patient. So it was found the ONEG unit of blood was 21 days old, which is still within safe, usable age limits. So why then were these values so far out of normal range? This is the part that intrigued me, and I began asking different questions like, how much potassium can accumulate in stored blood? Is there a point at which this will become toxic to the patient? What other values are affected with age? Questions that might be common knowledge to some, but for others and students such as myself who don't know, I thought I'd investigate a little and hopefully explain a bit about this topic. The first resource I found was a very interesting journal article in the Journal of Blood Disorders and Transfusion, in which a team of researchers took blood from 30 donors of a variety of age, sex and blood types and observed the changes that occurred in donor blood as it aged. It was stored at 4 degrees Celsius for a period of 21 days, with values such as the pH, AST, serum phosphorus, serum protein, serum chloride, sodium, potassium and bicarbonate levels all being monitored. By the end of this 21-day trial experiment, they found increases in serum phosphorus, AST, serum protein, calcium and potassium levels. Most importantly, the researchers saw a 522% increase in the potassium levels at the end of the 21 days. For the other values, pH, serum chloride, sodium and bicarbonate levels all saw decreases, with the highest being 79% decrease seen in the bicarbonate value. Now, if we refer this back to a donor sample, we actually saw this in effect. The aged blood saw a high increase in potassium, along with a decrease in sodium and bicarbonate. But before I move on with this, I figured I should briefly cover how these values are actually affected with age. Now please note here, I definitely don't have the time or the knowledge to cover in any great depth exactly how this occurs. Rather, I'm just going to touch on the surface. So once blood leaves the body and goes into storage, it has a limited concentration of glucose and thus a limited concentration of ATP. As these levels decrease, the energy needed for ATPase pumps in the red cells decreases. In normal conditions, this pumps 3 sodium ions out of the cell for every 2 potassium ions pumped in. The decrease in energy leads to the inhibition of the sodium pump, and then further leading into a hyperkalemic state from the accumulation of potassium ions. The anaerobic glycolysis the cells keep undergoing outside of the body causes increased concentration of lactic acid buildup and thus begins decreasing the pH, which in turn has an effect that stimulates cell homolysis, further causing the release of potassium ions, which will account for the exponential increase in potassium we saw in our patient. The decrease in bicarbonate levels are due to the buffering of excess lactate produced by cells undergoing anaerobic metabolism. Okay, so now we have covered what values are affected with age and briefly how this happens. Due to time restraints, let's stick purely with the potassium value. One of our other questions was also answered of how much potassium can increase with age, with the past study seeing it increase up to 522% of the original value. Now let's explore at what point this could become too toxic to give to a patient. In order to do this, I first researched what the minimum lethal dose of potassium would be. Given intravenously in the form of potassium chloride, the lowest lethal dose has been stated to be 0.77 to 0.9 millimolar per kilogram, depending on the rate of transfusion. Using this information, we can make a mock example to find the minimum lethal dose. Our patient in this case was a 21-year-old male. Unfortunately, we weren't given his weight, so let's use an example of 80 kilograms based on his age and sex. Taking this average weight, we can calculate that it would require roughly 62 to 72 millimolar per litre of potassium chloride injected intravenously to be a lethal dose, killing the patient. Also note that this dose would need to be administered in a very short period of time for it to be actually effective. So if we were to compare this value to the value of the Medivac ONEG unit that we used on our patient, it had a whopping potassium level of 33.8 millimolar per litre. And it is unknown to me at what time frame this took to transfuse the whole unit to the patient. But if we were to refer to normal transfusion events, this generally takes place over 1 to 4 hours. So while this specific potassium value does seem very high, firstly, the initial dose of potassium in this instance is not strong enough to be lethal for the patient, and furthermore, the rate of transfusion would be the limiting factor in its toxicity, as it would eventually become more and more diluted in the patient's peripheral blood as it began circulating. This would mean that for a lethal dose of potassium to be administered via transfusion would require a huge quantity of aged blood to be given. The conditions under which this would be possible would need to be incredibly specific, with some sort of severe trauma in which the massive transfusion protocol would begin. The patient would then have to have received at least 10 or more greater than 20-day-old blood units in a very short period of time before even coming close to the minimum lethal dose. So the chances of this happening are very slim. And if a scenario such as this ever did arise, the possibility of sending the patient into a hypokalemic state would most likely be the least of the patient's worries. In summary, the changes that undergo with donor blood unit after collection, processing and storage is incredible. The amount of biochemical transformation and continued reactions that affect the components of the blood as it ages, along with how that effect can then result on the patient, is simply amazing. This short presentation was able to look into the investigation of a misguided transfusion case and explore into the changes in iron concentration in red cells while in storage. Furthermore, the changes and effects that potassium specifically has on a patient and the amount that it can accumulate within a blood bag. This was only just touching the surface of this field, and there is so much more depth that can be explored with this topic, and so many more questions that need to be answered. I thoroughly enjoyed looking at this topic, and I hope you enjoyed listening. Thank you very much.
Any brave people in the regions want to ask Jordan a question?
Jordan, I'll ask you a question.
I've got a question as well in Emerald when you're ready.
Okay.
Jordan? Yep.
Okay. Do you guys have a protocol with your trauma packs? Do you make sure they come back to laboratory at a certain time? Like we only make sure ours are changed when they've got less than 10 days to expiry. So now I'm wondering if we should be doing it so that they've got less time as well after hearing your talk, because I didn't realise that happened. So that was good, thank you.
Excellent question. Have we got anybody from
Regional labs, we have them returned within a week of expiry. So, but they are not used. They are just used for just a regular top up. And it's done over 4 hours, so you're not going to have the potassium. Yeah. But for any of our blood here, they're a lot shorter expiry. So we're looking within 2 weeks. I think we use the ones that ONED. But regional labs, because they're not given the quantity, like you only usually will give an ONED bag, like one bag, and then they're usually transferred.
Yeah.
Answer your question?
Yeah, I was just wondering if maybe we should have been bringing them back earlier, that was all. So, cool, thank you.
That's right.
Emerald.
Hi, Jordan. I'm just wondering, the anticoagulants used in those bags in the units by Red Cross, do they have any effect on the chemistries?
I only briefly looked into the bags themselves, so I don't know how much I can help with this question, but from that, I'm going to pass this one to Hayley.
Would you use your resources there?
No, we can sometimes get citrate toxicity in patients, and it affects the coags really badly, particularly if they're apheresis patients, and they actually monitor them for citrate toxicity. And if they accidentally collect a coag on someone who's had a lot of apheresis units, you'll just get zero coagulation on anything, like everything will be greater than 200, and you'll be scratching your head trying to work out why. And we actually don't have any protocols to correct for that. You just have to know that they shouldn't have collected that coag sample from the apheresis patient. But it's citrate, massive citrate toxicity, and it gives you like a metallic taste in your mouth, and I think they can reverse it, can they?
Yeah, well, that's the good thing about using citrate.
So yeah, there is. Yeah.
I was looking into the PVC, the blood bags they used for them, and how they were making it permeable for the oxygen and carbon dioxide to leave, so that there wasn't so toxic in the blood. That was pretty interesting. If I had more time, I would have gone further in it, but I did not have time.
You did a really good
All
job.
that Red Cross stuff is really
You really, you did the case justice. That was good. Yeah.
good job.
Any other questions?
We'll leave you at this one.
You deserve to start.
That's all right. So, Marky, you're happy to go last, are you?
Different markers, no.
Yeah, I'm
He's also.
Are you waiting for us to run out of time?
Absolutely.
Now this case is totally different from the other cases.
Yeah, all right, thanks.
Completely
That's
different. Yeah, since everyone's been presenting transfusion heme and coagulations, my topic is totally different, which is a field that is not really urgent. In other terms, not really urgent, but I just have to appreciate how much work and effort put in there just to diagnose one patient itself, because as we all know, most of the other stuff can be done through automated, whereas this is mainly hands-on stuff, and basically understand the load of it is like 500, 400 patients a day, and in order to do that continuously and make sure it's accurate, so that way the patients cannot be wrongly diagnosed, which is important. So yeah, it's more about histology wise, so hopefully everyone's enjoying it. And it's a very interesting case. It's more about an accident case actually. The patient is very lucky and fortunate for the patient itself.
You want to make it full screen? See at the top where it's highlighted in blue, the square?
Okay.
Yep, on the right. No, to the right of that one. That one.
There you go. Sorry about that. Good evening everyone. Tonight I'll be presenting clinical case of mediastinal melanoma. And the purpose of this presentation is just illustrate the importance of laboratory scientists, basically, the role of the scientists play in the diagnostic processes. Now, we're presented with the case study of a 58 years old male Caucasian patient. It's a smoker, heavy drinker, and quite obese. The patients have clinical histories of benign cysts on the left breast or left chest. The mediastinal mass was discovered incidentally post-fractures of the clavicles when the patients are in the shower, onto the shower, and so the patients went to the hospital and take an X-ray and they find a mass, which is yeah, that's what the case continued. And the patients have no previous history of melanoma or any histories of visiting an oncologist itself. In this case, how are the health interventions, how are the role of the anatomical pathologists, also the scientists and the support staff involved in this investigation part? So it's crucial to determine the natures and the course of the mediastinal mass studies is crucial for the well-being of the patients. In order to accomplish the task, this required an enormous resource, manpower involving the patient clinician, and also the laboratory scientists and supporting staff that aid in the processing of patient specimens, reporting the results to the requested clinicians. Also, this presentations was to demonstrate how the roles of lab scientists supporting the staff contribute to the patient's outcomes itself. Now, the primary source of the immunocytose is unknown. At this stage, there's no clinical histories of saying where the primary is, but it could possibly originate in the immunocytome itself, which I have looked up. It's very rare case, probably about 1%. It's very rare case itself. However, it's not clinically relevant in this case. The main concern is to determine whether they're benign or malignant mass, and if it is malignant, what type of malignant it is, and its correct diagnosis can be essential in developing the treatment plan for the patients itself. Therefore, biopsy immunocytoma mass is necessary for clinical diagnosis. The surgery procedures carried out to obtain the mass by sorry, just a long name. Now, a small surgical is made in the above the breastbone, as you can see again, and the immunocytoscope is inserted through with a biopsy instrument to remove the specimens itself. In this case, the specimens actually removed is none of them that correlate to any cells that produce malignant. Basically, it's fibro adipose tissues and fibroconnective tissues, which is very rare. They don't produce melanin. And now, after we remove the biopsy, now the biopsy is sent to the AP lab, which is anatomical pathologies. Now, I'll just run through just how the lab works, how the flow, how the layout works. And the figure on the right here presents the layout of the anatomical pathology lab. As you know, the anatomical pathology discipline is very labor intensive. Most, I've happened to be there. Now, the laboratory is divided into 3 sections. There you can see here, it's basically 3 sections. So the beginning section here where it's receiving everything else. First, the sample is received from the CSR. A non-scientist is assigned to the anatomical pathology session number. So there's a new number of sessions. So basically, because we have to store the samples for a prolonged period, probably about 10 years, 15 years, depends on the cases, but it will be massive. So instead of having the patient number, what happened? They use a new IEMR, which is connected with the lab. So basically now in the lab itself, they provide another session number, so that way they can follow up in terms of rather than the patient numbers itself when provided. Now, secondly, in the growth sections here, you can see the sections most likely for the biopsy specimen, the patients, their macroscopic descriptions are done by the scientist itself, not the pathologist. Only certain very more comprehensive one will be dictated by the registrar. Now, the macroscopic dissection specimens, in this case, a multiple piece of the fibroadipose tissues and fibroconnective tissues with the measurements of 6 by 6 by 2 in aggregate. The biopsy itself, now in this case, small biopsies are in a pin cassette because every cassette is a different label for specific cases and also based on the specimens itself. It's labeled and then it fixes for at least minimum for about 12 hours before we go into a third stage, which is tissue and processing stage itself. Now, after fixing the tissue cassette is placed into a tissue processors for approximately 2 to 3 hours. Basically, you go through is just to remove all the lipids and everything else, and also silane, which is clearing, and also infiltrations by the wax itself, so preserve the tissues itself. And followed by that, the second section is where the production mainly is in this center area around here, where the tissue is embedded. Embedding is a very important part of it as well, because if you're embedding correctly, we're able to represent what the clinical is about, But if you embed it wrongly, then the pathologists won't able to observe anything else there. The whole process has to be repeated again. So it's a very wasteful process. Now, here is also a sectioning section, which is cutting section basically, very labor intensive, I guess, and very heavily trained, I guess, for long. So the sections is cut by 3 micron, depends what the phase is 3 microns. Sometimes it's 1 for nephrons to see all the features and everything for diagnostic purposes. And lastly is the analytical reviews for pathologists and everything like that. So it's a convoluted kind of process where from the pathologists have to go back to this lab scientists in order to order another test, so the test evolving until the diagnosis is complete. So now, now in this case, the microscopic report after we complete everything else, the routine H&E, which is hematocylin and insulin staining, were analysed by the anatomical pathologist. The tissue slice shows, I'll take that photos, just one of them, but mainly it's a very nascent islands of neoplastic cells. In this case, it's just a small one from it. So you can see from here, you see all these cells, the adhesion cells, the adhesion of the cell, just using out the adhesion, and mainly you can see the binuclear form, and also some really marked polymorphisms, as well as you can see some vesicle within the nucleus itself. There's some of these vesicles here within the nucleus itself. So that is the nucleus itself. So mainly the cytoplasm is just ruptured already. So in this case, they will confirm it is a malignant neoplasm, but we cannot confirm which type of malignant it is. So additional tests are required to confirm the diagnostic suspicions of malignancy. So now it comes to these, which is a very important part. It's called immunohistochemistry. So basically, we have what's called a rule-in, rule-out panel. So rule-in, rule-out panels, basically what we first rule out is very common is carcinoma, lymphomas, and melanoma, which is very common. And first, once we rule out carcinoma, what we do, we stain it with the AE1 and AE3, which is very special to this area of epithelial cells, which is represent most of the carcinoma. And also we stain for CD3, CD20, CD45, or to rule out any lymphoma or non-Hodgkin disease as well. And to rule in to confirm that if it is a melanoma, so what we do with a whole series of stains, so SOC stains, which is, well, in this case, everything is kind of like a dark brown, which is positive. We also have all control to make sure that it is correct. So by all of that, so now we can conclude that it is a infiltrated melanoma in this case. Now, in order to further that for treatment-wise, because there's no point of we testing, but then what was the end result for the patients itself? So now, to further that, what we do is in melanoma, mainly in this case, we have the called BRAF mutation. So it's mutation, the V600E, which is valine, is it's been glutamic acid is substituted into valine. Valine is substitutes glutamic acid because of the mutation of the BRAF here. So following the IC panel, the addition BRAF VG protein IHC, which is immunohematocrit stain, was formed to confirm the cause of metastatic melanoma. The BRAF gene encoded proteins developed with the RAF families, a serine and threonine protein kinase. It plays a role in regulating the MAP kinase and ERK or ERK signal pathway, which affect cell division as differentiations as well. The BRAF V600E mutations are most frequently identified in cancer-causing mutations in melanoma. The top right diagram illustrates positive detections of the BRAF V600 mutations, further assisting in the development strategy of treatment molecular testing also performed as well in order to confirm the actual locations of the mutations, so that way specific treatments can be done. So in this case, what we find in the molecular testing is that we can find here, if you can see that, it's, up here is the reference genes, and the bottom here is actually Q, which is a patient's aligned gene. So basically we can see that normal in the reference genes A is present, which is adenine. Now it's been replaced with thymine, which is start causing the mutation, which is in the transcriptions. Glutamic acid was transcribed instead of valine. How that works in helping the patients and treatments itself. In this case, we find that the BRAF, there is an inhibitor that exhibit the BRAF here is actually sensitive to inhibitor, BRAF inhibitor, so which help in a lot of diagnosing and also treatments for the patients itself. One of many effective treatments is this particular BRAF.
Well, it's a TV, you're going to continue.
Let's continue.
They should be there, right? There they are.
Thank you, I'll be here all night.
So just to repeat that one. So what does all this mean for the patient? In this case, the pathologist has now reported finding the patient clinician determines on the appropriate treatment strategy based on the locations that was detected using the molecular test, which is now detected, where this is the cascade of the MAP kinase, which is communication transcriptions of the DNA, how cells divide, how cells differentiate. And so in order that, so there's a drug, for example, there's drugs that are vemurafenib. It inhibited the proteins here, which is stopping the cascade, which is stop these cells from further differentiate and divide itself. Now, to conclude this up, now, how the role of this is more important in the lab sciences itself. In a clinician's perspective, what the lab scientists do is ensure that all the sample that provided is preserved and properly is sufficient enough to perform the test. And to the pathologist itself, we make sure we ensure the accurate result we provide in a timely manner for the rapid clinical diagnosis, and also indirectly from the patient's perspective, patient's outcomes relies on validated results and for correct diagnosis and that aid in development and treatments of the strategy which improve the health and well-being of the patients itself. In this case, the patient was fortunate enough to undergo treatments because of this finding, which was very fortunate for the patient based on the findings itself. Thank you.
Regions.
Can I ask a question?
Yes.
Just not to make you feel left out. So what's one of the major dangers of that a scientist can make when dealing with cutting small biopsies?
The major thing, it depends on which one it is, but the thing is, when cutting it, half the time we cutting this the sections itself, sometimes it's difficult to cut. The scientists might put up higher, so in terms of let's say instead of supposed to be 3, they cut it at 5. It's very difficult for the pathologist to recognize the underlying dependent tissue, the complexity of the tissues itself. And also when you're staining, it can affect the outcome and the result of that. Therefore, it's a very fine margin between, so sometimes if you, let's say for example, if more tissue, the stain is more intense, then it's hard to recognize the difference in between different cells. Yeah.
I find pathologists can usually recover from that because they'll just be able to, if they're quite skilled, they can still make a diagnosis. One of the major problems people can make is if they don't block the tissue correctly, if it's on a slight angle, and then what they call it facing the block, and they cut too far into it, you can completely cut away a small biopsy. And when it's something really significant like that, like we saw the medical procedure that person had to get to have the tiny little biopsy, and they just call it facing through the whole sample, and then once you do that, it's gone. You can't really reblock it.
Correct.
So I have seen that.
Correct. Yeah, I think
It's a bit
so.
stressful. You've done it.
Yeah, that one's in most of the renal. That's why certain so we got they
So
have
small
it like
box,
a colour.
they
Yeah,
usually have
they got colour
more
coded.
experience.
They got colour coded. So basically, the less colour coded, which is white ones for those with less experience.
Yes.
The more colour coded.
So when you work in our lab and you learn history, you get to cut the morgue blocks.
I was mainly learned to cut.
Plenty more tissue to go back to.
Post-mortem. Mainly post-mortem.
Exactly.
Yeah, mainly post-mortem.
It's much less stressful than having fine melanoma biopsy.
Any other questions? Okay, well done. And surprisingly, our last speaker tonight is one of our past students who's come back for more. Yay. Go figure. Must be feeling left out.
Sucker for punishment.
I'm also not about that standing life, so I'm just going to sit here.
There's no camera on you.
Cool, even better.
No, dude, I'm marking you down.
You can write whatever you want. Okay, so good evening, everybody. If you don't know, my name is Michael, and I'm the graduate scientist based here in Townsville. Today I'm going to present a case study about a rare hematological syndrome called hemophagocytic lymphohistiocytosis, more commonly referred to, for the sake of sanity, as HLH. So I'm going to give a quick overview on some of the background of HLH before we actually jump into the case study. And before we go too much further, I thought we might take a quick look at the name. It is a bit of a mouthful, so I've broken it down into its component parts and put some translations underneath it, as close as I could make, which frankly did literally nothing to help me understand what this disease actually is all about. But the best sort of sentence summary, if you like, of HLH I could find is that you see it there. It's a rare immune activation syndrome in which certain cells proliferate and begin to damage body tissues and organs. So if we go a little bit deeper, the question being, what is HLH? It's often broken up into a primary and secondary, otherwise known as a genetic or familial and a sporadic form. It's probably a bit of an arbitrary distinction because a lot of the sporadic cases or secondary cases have a genetic component, or at least a predisposition that's identified. So yeah, I want to point out before I go too much further as well that a lot of this stuff is not fully understood, so there's a lot of potential for more research to actually understand how this all works. But the pathogenesis, or rather the mechanistically, it looks like HLH arises following an inappropriate activation of macrophages that will induce a cytokine storm. A cytokine storm releases huge quantities of pro-inflammatory signaling molecules that will directly or indirectly cause cell damage and death. Some of the main culprits you can see here are interferon gamma, TNA alpha, your interleukin 6, 10, 12, and soluble CD25, which we'll come back to in a minute because it's got a bit more of an important role. For the lympho component, it's basically that the lymphocytes or lymphocyte-mediated killing of those macrophages is actually impaired, which is commonly seen as the genetic abnormality. So, moving to primary HLH, as I said, it's a bit of a misnomer because most forms do have a genetic component, but in terms of those that are de novo or arise solely from genetic mutations tend to be more in children, even infants. And yeah, the most, as I see here, the most well-described forms are caused by mutations in PRF1 or UNC1-3B genes. But again, it's there's more. The genetic cause, all the genetic causes have not been identified, and you can see even FHL1 in the table there. It actually has an unknown gene. Press the wrong button there. So secondary HLH, as you can see from my table on the right there, has an absolute plethora of possible causes. It is triggered by an immune insult, and the most common causes you'll see will be viral and malignant, specifically EBV and B lymphoid malignancies. But yeah, there's absolutely massive variety. You can get it from, there are cases from rising from Babesia infections to Clostridium difficile, Aspergillus, Helicobacter. Yeah, it's very much a case of the right or wrong condition giving rise to this condition. So, how do we diagnose it? Well, based on the HLH 2004 criteria, developed in 2004, there are 8 major diagnostic features, 5 of which must be present. I've color-coded them based on when they were originally put into the diagnostic protocol, but honestly, they're all equally used these days anyway. But the point of this is that you can see they range from very non-specific, such as fever or organomegaly, right down to the more specific ones, which is your low absent NK cell activity, the hyperferritinemia, and the really high soluble CD25 receptor level. So yeah, interleukin-2 is the other name for that. Yeah, but so another, you can get a molecular diagnosis, as we mentioned, with the familial HLH. Another diagnostic criteria exists. So the more recent one is the H-score, which determines probability of HLH through a point system that is broadly similar to the 2004 protocol, so I'm not really going to go too much into it. Clinically, you can see any number of things. I've basically put all this here to point out that it's non-specific. It's difficult to diagnose based clinically. In fact, you can't diagnose it really clinically, simply because there's so many non-specific symptoms. So treating HLH, it's very difficult, as there is with any syndrome of immune activation. Familial HLH is particularly devastating. It has a very low survival rate. As you can see, median survival of 6 months and less than 10% beyond, much beyond that. And the sporadic HLH, it's a case of you have to treat the cause before you can treat or rather you sort of, it's symptomatic relief more than treatment of HLH specifically. So you treat HLH or sporadic HLH by a severe immunosuppression or immunosuppressive therapy, and then you try and find what's causing it, treat that, and that should alleviate HLH. But the treatment regime you can see here at the bottom here is basically lots of immunosuppressive drugs, and VP16 is etoposide, which is a chemotherapeutic agent. So, with that background covered, I thought I might go into the case study. So the patient was referred to ED by his GP, who noted a fever and a ferritin of 12,000. Again, ferritin of greater than 500 is considered extremely abnormal. This guy's was 12,000. And presenting again with non-specific symptoms and a rather unremarkable patient history, although later we did find evidence of an EBV infection. His condition rapidly worsened. As you can see from presentation, his bloods were not great, but within 48 hours he had dropped to critical levels. His LFTs were quite elevated, as you saw from the non-specific diagnostic symptoms before. That's not uncommon. But he also had hypertriglyceridemia and a hypofibrinogenemia. But alarm bells really began to ring when we did his iron studies, and he had ferritin of 10,000 and soluble CD25, which I've tried to highlight it here. I don't know if you can really see that. Upper limit of that is supposed to be 2,700, and he's sitting at 7,000. So a lot higher than it should have been. So a bone marrow aspirate was performed, and upon examination discovered evidence of hemophagocytosis. So these are macrophages that have begun to eat cells around them, mostly red cells, but on the one on the top right, and it's a bit hard to see on the screen, there's actually a neutrophil that's been engulfed there, possibly an eosinophil on the bottom right here. It's a bit reddish. But yes, so there's that evidence we talked about. Comparing what we saw in him to the diagnostic protocol, we can see that although there was no organomegaly to speak of, there was fever, there was cytopenia. He had both hypertriglyceridemia and hyperfibrinogenemia. He had hemophagocytosis in the bone marrow, hyperferritinemia. NK cell activity results are still pending, but at this point it's sort of a moot point. He's got 6, possibly 7 of the diagnostic criteria, so we diagnosed him with secondary HLH. But what prompted it? Where did it come from? It's not de novo. What's the trigger? Well, a PET scan was performed, and you can see particularly in the 2 pictures on the right-hand side of the screen there is a mass in his lung, which later was biopsied and sent through to the anatomical pathology department, where you can see on the right-hand side, so there's the 40 times magnification picture. On the right-hand side, you can see normal lung tissue, and the rest has just been completely taken over by whatever that mass was. Zooming in, I've circled 2 areas. The top left one is an example of a macrophage that's eaten some, you can see that on the screen, I hope. There's some hemophagocytosis going on there. And the one on the bottom right there just seems to be some sort of atypical lymphoid cells. And there's more here. This one on the left here is particularly spectacular. You can just see macrophages eating everything. All through these pictures, anywhere you look, it's just all through that. All through that mass, there's just this phagocytosis going on. So we performed a bit of immunohistochemistry, particularly a CD3 positive, which showed a massive quantity of T cells. And again, on the 200 times the total magnification one, you can see a particularly large, abnormal looking one, pretty smack bang in the middle there. On the CD68 marker, which is a macrophage cytoplasmic marker, again, you can see high levels or high presence. And again, with that total magnification. On the one on the left, you can actually see a macrophage that has engulfed several cells. The brown in this one, just to point out, is the cytoplasm of the macrophage. So, based on those criteria and what we can see in this, in the immunohistochemistry and in the H&E, there was a final diagnosis of a peripheral T-cell lymphoma, so leading his total diagnosis to being hemophagocytic lymphohistiocytosis that's secondary to a peripheral T-cell lymphoma. That was a mouthful. A couple of quick acknowledgements. I want to thank Ailey Ross for helping me understand some of the flow, Andrew Cross for helping me learn a bit more about HLH, Dr. Jane Raw and Dr. Leslie Kumar for help in making sense of all the data. And that's all there is to it. Thank you very much.
Any questions for Michael? No. Okay, any questions from Townsville? You've stunned them all into silence.
I was going to say, anyone who's not Ailey.
Now, we actually do flow peripherally? Or
Sorry?
bone marrow? Did we actually do the flow?
Yeah.
Oh, okay. Of course. Yeah, that was in his lung. So, what was the timeline of this patient?
Months.
So I think that's important.
Yeah,
We should
so he basically presented mid-January, and this diagnosis was made late May, early June.
Why did it take them so long to do a PET scan?
They did a PET scan, or they didn't do a PET scan, they did a MRI, I think, and saw a mass, or saw something on the medical imaging, which resembled a fungal, like aspergillus or some sort of fungal cause. I believe at one point they actually put him on a bunch of antifungals and they seemed to clear up, but then it came back again, so they looked into a different matter and yeah, as you saw by the PET scan, there was just...
Seems odd they didn't do a PET scan
big old
earlier.
mass.
Underlying malignancy is a pretty common cause.
Absolutely.
HLH, I'm just a bit surprised by that.
Yeah.
Because that PET scan...
Although it's more likely, the underlying malignancy is more likely to be lymphoid or like a leukemia, less so a solid mass, which might have been why they treated it. I can't speak
We did do a lot of flow
to what they were talking
and it was all negative.
Do you
But,
guys like
is this
culture fungal things from the lung fluid?
Yeah, we do. Yeah, they would have cultured that. Found.
Yeah, we did all the flow.
No.
Is this,
We did a lot
Yeah,
of
it's
lung
what's
space.
yeah.
Lung
Bronchial
fluids,
lavages.
We did lymphoma, we did peripheral blood. No T-cell lymphoma anywhere but in his lungs.
Wow.
Yeah.
But you get some pretty spectacular looking...
So does that make his prognosis better?
It's a work of art.
His prognosis is extremely poor.
Wow.
Just now we know what he's going to do.
Okey-dokey. Thank
Yay!
Well, thank you everybody for joining us tonight. I'm hoping that you'll all send me through a list of who's attended, particularly anybody that's out there in Cyberland. So let me know if you attended, so that if you want to have an APACE certificate, let me know. Otherwise, if you do claim your APACE points, if I've got you listed as having attended, you can